Okay, let's see. Okay, let's wait a few minutes. Welcome to the attendees that are slowly joining. We will wait a few minutes until we are all ready. Okay, we are, oh, it's rising fast. We are hitting the 50 barrier. Okay, let's wait a few more minutes. Give it a minute. Okay, the numbers are still increasing. We are 60, 66. Let's wait until 64, 67, 69. We want 70, at least. 70, here we go. Like, okay, there are still people joining us. Let's wait another few minutes then. Okay, I think now that the numbers are stabilizing. So let me stop the sharing of the screen and voila. So good afternoon, everybody. Welcome to this edition of the NITheP Colloquium. As you know, we started this NITheP new tradition in times of COVID, and so far they were very successful. And as you also noticed, the topics have so far been exclusively COVID related, but we will for obvious reasons. And one being that I think it's very important for the theoretical physics community to show that we care about the problems that are out there and concern all of us. Today, we are very fortunate to have Professor Bruce Bassett with us. Bruce studied at University of Cape Town, where he obtained his MSc, his master's in applied mathematics. He completed his PhD in Italy, in Trieste, and went as a postdoc to Oxford. Yeah, over a few stations in Portsmouth, at University of Kyoto, and so on. He ended up, I think, in 2006 back in Cape Town as a professor of applied mathematics at University of Cape Town and at the South African Astronomical Observatory, the SAAO. Yeah, he's also the head of data science at the SKA since a couple of years, and he's heading the cosmology group at Ames. Yeah? Bruce is by training a cosmologist, but he has worked very much in problems related to big data, optimization, and Bayesian statistics. Yeah? He's also the vice president of the International Astrostatistics Association. Yeah? And Bruce, we are really very happy that you agreed to speak to us today. And the title of Bruce's contribution is "How Hard Will COVID-19 Hit South Africa? A Story in 3 Parts." Yeah? Before I ask Bruce to start, I just would like to remind you about the rules of the webinar game. At the bottom of your screen, there is a black bar, and towards the right, there is a Q&A button. Yeah? And please make use of that facility to ask questions. Yeah? And above me, you see there is not only Bruce, there is also Dr. Sinaisky, who is a NITheP associate, and Ilya will facilitate the questions and answer session. So after Bruce's talk, Ilya will continuously monitor the question and answer facility and ask then Bruce the questions that the participants want to pose. Yeah? And I'm very pleased to tell Bruce that now we are almost 100 listening to your talk. So please, people are not here to listen to me, they are here to listen to you. Please, the floor is all yours.
Iterated. Please feel free to ask questions during the talk, and if there's any clarification that needs. It's very strange to give a talk sitting down, so I'm going to try and give it lots of energy like I would standing up, but that may or may not succeed. Okay, let's share quickly. Okay. All right, hopefully that everyone can see that. Is that okay, Francesco? Can you see it? Just the title slide?
Yeah, it's perfect. Thank you very much.
So yeah, you know, as Francesco said, I'm a physicist by training, so it's a little bit strange to be working on epidemiology. Like 4 or 5 months ago, if someone had predicted this, I would have laughed at them. So this is mainly work that was done at Soreo, you know, South African Radio Astronomical Observatory, with not Neil Armstrong, Richard Armstrong, Chris Finley, Nadim Uzziah, and Felix at Wamba at Ames. So it's a very strange thing to try and give an introduction to coronavirus. I think no introduction is really needed. It's obviously the biggest topic in the world at the moment. So we've gone past 5.5 million actual, you know, confirmed cases and 350,000 nearly deaths. So the key question that I think we all care about is how hard will COVID-19 hit South Africa? And really, this comes down to a couple of questions. One is, how deadly is the virus? And the second question is, well, how many people will be infected? And so those are the two key questions I'd like to address in this talk. And then perhaps we'll have some time for discussion of what do these results mean for South Africa. So the first thing we want to know is, how deadly is the disease? In other words, what is the probability that you will die if you get infected? And that is known in epidemiology as the infection fatality rate, IFR. So that's a quantity I'll talk about a lot. So IFR is the probability that you will die if you get infected. Okay, so it sounds like it's quite an easy thing to calculate, but it's actually really hard for a few reasons. So let's go through some of those. So the first thing you might say is, well, let's estimate the IFR by taking the number of people who've died and dividing it by the number of cases. So for South Africa today, that would be 429 deaths. And we've got 22,583 cases. And you say, okay, the death rate is 1.9%. That's completely wrong for several reasons. Okay, the first is that we're clearly missing cases, right? Tests, confirmed cases is not the same as actual numbers of cases. And so this is very common in astronomy. We call it Malmquist bias, that you know that you're missing most or many examples. In the case of COVID-19, testing is limited. Ideally, we would like to test every single person in the country every day. Then we wouldn't be missing any cases. But we know that we're probably missing at least 70% of the cases, maybe 99% of the cases. The other problem is the deaths. 429 people have died today, but unfortunately, many people who are infected today will die in the next month, because there's on average a 14 days delay to death. So that means that we shouldn't be using 429, we should be using a bigger number. So the 429 should be bigger, but the 22,000 should also be bigger. And then finally, there's going to be missing deaths, people who die at home or in old age homes or in the country who never get tested, but who die of COVID. And in Italy and New York, it was up to a factor of 2 undercount in the number of deaths. So, you know, we have to deal with all of those. Any questions there? Feel free. Ilya, has anyone got a question about this? Because this is really important about the IFR.
No, so far not.
Okay, perfect. If you have any questions, please just raise your hand. So the first problem is the missing cases. Even this has 2 factors. The first is that the disease is very clever, in inverted commas, because a significant fraction of people who have the disease basically show no symptoms. They're asymptomatic. They may not even know that they have the disease, but they may well be infecting other people. So in terms of a strategy for infecting people, it's very clever. So of course, if people have no symptoms, how do we know we should test them? And, you know, we don't know what the asymptomatic fraction is. It's probably somewhere between 10 and 80%, more likely to be somewhere between 20 and 60%. More serious is that we can't test everyone. PCR, which is the standard test for viral load, is very limited at the moment. So typically, only severely affected people get tested. And the problem is that if you wait, like I had a COVID test about 5 weeks after my symptoms started, it came back negative. But the problem is the false negative rate after a few weeks is above 50%. So I actually don't know whether I have COVID or not. I certainly feel crap anyway. So the real question is, how many of these infections are we missing? Are we missing 20%, 90%, or 95%? And that changes the IFR completely. So just as an example, let's look at Sweden. They've had about 33,000 cases and 4,000 deaths. So that's about 12% naive fatality rate. But look at Qatar. They've got 44,000 cases and only 23 deaths. So the difference between their case fatality rate, so the case fatality rate, the CFR, is the number of deaths divided by the number of positive tests. The CFR, they differ by a factor of 200. And so why is that? Well, one of those is clearly that different countries are testing different amounts. So here I plot on the x-axis the number of tests per million people in the population. So here 10 to the 5 means you're testing 100,000 people out of every million, so 10% of the population. And over here you're testing, 1 out of every 100,000 people. And against, on the y-axis, I'm plotting the crude fatality rate. So this naive estimate of fatalities, number of deaths divided by number of cases. And these are exponential, these are all logarithmic plots. And you can see there's a general trend that the more you test per capita, the lower the fatality rate. So we know that this testing is a key factor. But the problem is, we don't know what the infection fatality rate would be if you tested everybody. That's the million-dollar question. So, in fact, some people said, actually, you know what? COVID is just another flu. It hits us very rapidly, and so a lot of people end up in the ICU, but actually the fatality rate is basically like the flu. And so that was a big question. And so how can we address whether that's true or not? Well, you can see that I think the answer is no, and I'll try and convince you why. Well, the IFR for influenza is typically quoted as being less than 0.1%. That means less than 1 out of 1,000 people who get flu die. Well, what about COVID? Well, we don't know what the infection fatality rate is for COVID, but can we get a lower bound? Is there a number that we are sure COVID is the IFR is higher than this number? And the answer is yes, we can. We can just assume that everybody in a given region has been infected and use that population of that region as our estimate of the number of infections. That will give us a lower bound because we're dividing by a number that cannot get bigger, right? So here's the example that I did is I took New York City, 8.5 million people, Lombardy, 10 million people, and Madrid, which is about 6.5 million people. And if you add up the deaths in those 3 places, you get to about 44,000 deaths. And their total combined populations is 25.1 million. And so if you just divide those two, you end up with an average IFR across those 3 different countries of 0.18% as a minimum. It's a minimum because we assumed everyone in New York and Lombardy and Madrid were infected to get this number. So clearly it's not true. We wouldn't expect, in fact, serological blood tests suggest that, in fact, not more than 20% of people in any of those regions are actually infected. But by assuming that everyone's infected, we get a lower bound. So that conclusively proves that COVID is actually at least a factor of 2 worse than flu. Unfortunately, it's probably more like at least a factor of 10, but at least we can prove it's worse than flu. Are there any questions now, Ilya?
Yes, in fact there is.
Right.
And Rob Adam is asking, is a daily running count of deaths divided by recoveries plus death is a meaningful statistics?
Yeah, great point. Thanks, Rob. So since you know that a lot of people will die in the future, you can get a useful statistic by taking the number of deaths divided by the total number of resolved cases. And typically what happens is that will go up because people die quickly and recoveries tend to be very long. And then it will reach a peak and then it will start to come down. So it's a very time-dependent quantity. I don't actually have a graph for it, but on my Twitter account, you can dig back and see. And that ratio does converge to the true case fatality rate. It doesn't help deal with the fact that you're missing many cases, but it does give you sort of something sensible in the middle, in the thick of things. Yeah.
Okay, that's the only question. Yeah.
Okay, perfect. So, this question about the IFR is difficult for other reasons too. One of them is because it's sort of not sensible to talk about a global average IFR. The disease and its spread and its fatality rate probably depends on a lot of factors. I list a few here. We know it's very strongly dependent on age. For some reason, it doesn't affect young people very much. We know it's very strongly dependent on comorbid diseases that you might happen to have in addition. Things like BMI, population density is quite important in how it spreads, the quality of healthcare, number of ICU beds, cultural factors, for example, whether people are used to being close to each other, genetics, blood type, climate, vitamin D, are there multiple strains? There's many factors that probably will change the IFR. So what do we mean by an average IFR? It's a very difficult thing. So let me just comment that there are actually now probably more than 10 or 15 studies claiming to have detected at some level of significance the fact that some of these factors are important, like blood type, like temperature and humidity. In fact, I put out a blog post on that, I can't remember, in February perhaps. Then there's things like BCG vaccination, the tuberculosis vaccination, people claiming that has a big effect in moderating the spread of the disease. So are these correct? So this is work with Chris Finley. So I'll just give you the results of that study. So first of all, let me say that if you look at the growth rate, the daily growth rate of deaths, you do see a big spread from country to country. So here, 1.3 means that the growth rate increases by about, the number of dead people increases by 30% per day. Down here, San Marino is somewhere around 7% per day. And you can see there's a whole bunch in between. You can see United Kingdom, Spain, Germany, Mexico. So there's a lot of variation there. And you might wonder, well, what's causing that? This is very difficult analysis to do, though, because here are the deaths on a log plot, deaths versus time. And you can see that a perfect exponential growth, which is what the standard disease spread would be a nice straight line. But you can see they all they're often quite nice and straight, and then they'll tend to bend over. So why do they bend over? At least two reasons. So one is countries react, right? We are not mindless automata. We see that people are dying, and so we change our strategies. It's how humans came to dominate the world. We adapt, and we do social distancing, the government's introduced lockdowns, etc. So we have to be careful at splitting out the part after people start to respond and only look at the part where the disease is spreading exponentially without interventions. So the red parts are the parts that we examine, and you can see there's a different part. So we cut off the parts as soon as social interventions start to have an effect. So these are the results. Unfortunately, it's not particularly good news. So these are histograms of, for those of you who know statistics, these are posterior samples that allow for all of the uncertainty. This is a Bayesian hierarchical model. I won't go into the details, but essentially we are allowing the model to ascribe some of the variability that we see in this data. We're saying, if you want, you can ascribe it to climate or to BCG. And the value on the x-axis is how much, in a sense, how much value it ascribes to that parameter. And you can see it says that BCG is not interesting at all. It doesn't care about BCG as a factor. For temperature, you can see that it actually does like the temperature to be pulled away from 0. But for those of you who are statisticians will know that there's still a significant amount of area consistent with 0. So we are seeing something between 1.5 and 2 sigma evidence for temperature. For humidity, again, there's a little bit of an effect for humidity, somewhere around 1 to 1.5 sigma. But these are very weak and consistent with no effect. We also ask, does the number of tests per 1,000 population play a significant role in predicting the number of dead people? And you can see, well, not really. There's a little bit of evidence for it, but it's pretty speculative. So maybe temperature is relevant, maybe humidity is a little bit relevant, but within the error bars, no significant detection. How about the positive fraction? So positive rate here is of the number of tests that a country has done, what fraction of them came back positive? So South Africa has done, 500,000 tests. We've got 20,000 have come back positive. So South Africa would be at 4%. In some countries, it's up at 20%, 30%. And there you can see that 0 is inconsistent with the data at more than 3 sigma. So the only factor that we detect at more than 3 standard deviations is this positive rate. Blood type, we looked at all the blood types. The one that looked most significant was the fraction of A positive. And in fact, again, there's no evidence for blood type being relevant. There's evidence that, or people have suggested that vitamin D deficiency is a strong predictor for mortality. So we didn't have vitamin D factors for population. So we looked at ultraviolet index, which of course leads to production of vitamin D. Unfortunately, we find no evidence that the UV index is significant. So what does that mean? Well, it means that there's a little bit of evidence that temperature might be significant. That's bad news for South Africa, of course, because it's a negative correlation. So it means that colder temperatures lead to more effective spread of the disease. The same here, drier is better. So, drier is, wetter, more humid is better for stopping the spread of the disease. So for Cape Town, in fact, if you take these best fit values, they basically cancel out. The reduction in temperature is compensated for by the increase in humidity. But I caution that this is, we are not detecting this at significant level. But if this was true, if you take the best fitting values, you would say things would definitely get worse for Joburg because it becomes both drier and colder. How should we interpret this positive rate? Well, what that's saying is that in a country where they have a high positive rate, then the deaths grow faster. The growth rate for deaths is higher. Now, in a sense, that's kind of obvious. If your healthcare system is overwhelmed, you, for whatever reason, are falling behind the curve. So it's not really a causative explanation. I think this is just a correlation. I don't think it's causative, of course. The interesting question is, it begs the question, is there more than one strain, or is it just some other factor that we don't know that's causing a few places to really take off? So unfortunately, no good news for South Africa there. And just to show you, this is the data on the y-axis. There's the growth rate, daily growth rate, against the positive rate of positive fraction of testing, and you can see that countries that have a higher fraction of positive tests tend to have a higher growth rate. We don't know why that is yet, so that's an open question. Yeah, any questions on this part? I had to go through fairly quickly, so there may be clarifications.
Okay. Then. Thank you. There are a couple of questions. One question is from Danny Adams, and it's the question is, how are the people immune to getting the disease taken into account?
Right. So in this, thanks, Danny. In this analysis, we have not included any immunity issues at all. We have simply looked at this data. These are the number of deaths versus time, and we've simply fit exponentials to that, essentially getting a daily growth rate of deaths. And then we ask, can this variance in the growth rates be explained by factors like climate, BCG, pollution? I didn't mention pollution also doesn't play a role in explaining this. So in other words, whatever is causing this variance, it's not the factors that we've looked at. So in other words, it could be something very simple like population density may be enough to explain this, or cultural factors. These are things that we know would have an effect. If you go around kissing people on the cheek, like it's common in Italy and Spain, it's obvious that the disease will spread faster in some sense.
Okay.
Yeah.
And another question is from Vincent, and it's, what kind of multiplier would make sense to determine the true number of infections, looking at the number of confirmed infections, the amount of the tests done, and the total population? As an example, the Netherlands is looking at roughly 16x based on 4% of population having immunity, based on blood bank samples that are considered a very good representation.
Yeah, so that's a great question. And to a certain extent, that's still the million-dollar question. We can go about this in a couple of places. There are a couple of places where everyone was tested. On the Diamond Princess cruise ship, everyone was tested. And there, the average IFR came out to be somewhere between 0.4 and 0.8. In Vaux, the little town in Italy where they tested everyone, they had somewhere around 50% of people were asymptomatic. The serological tests that you start to refer to, these antibody tests, which test whether people have had it at any time, for Spain and Italy, they're coming back at like somewhere around 5%, which suggests that you should multiply by roughly 10 times. So unfortunately, we were hoping that it would come back at saying, 25% of people are infected. That doesn't seem to be coming back. But I would caution, the other thing is the antibody tests, the false positive, false negative rates are still somewhat uncertain. So I'm still reserving judgments. But I think 10x roughly is probably reasonable. Certainly 5 to 30x, I think, are still compatible with what we know. Given these assumptions, these results are typically quite model dependent. So when you change your model, your numbers will go up and down. And I think that's where we have to do a lot of work to improve the total numbers to understand.
Okay. And we have one question from the Mike Murray on the bias in the testing. So when testing, do all countries actively test those they think are showing the symptoms, or do they randomly pick people to test from the population? Will this bias the positive rates result across the countries?
Yes, I think most countries have taken a policy to test this people who are symptomatic, and the problem with that is that exactly you have no idea how many people are asymptomatic and not affected. So I'm very disappointed personally, as a statistician, that there are not serious attempts to do randomized testing. They're starting to do it. It's serological tests are in some sense doing that, because in principle they should be sensitive to anybody who's had it. But yeah, you need to do it at a very large scale to get a really good estimate, because we know from Spain, for example, that the prevalence varies by a factor of 5 across the country. So it's a little bit like trying to figure out who's going to win an election by sampling 1,000 people randomly. To do it really randomly is quite hard. Yeah. But that's, I think, is a key thing. And I hope people do it seriously as soon as possible.
Okay, that's it for now. Thank you.
Awesome. So our conclusion is that there is no evidence for BCG, climate, or blood type having an effect on the spread or pollution. This doesn't mean that there isn't an effect. It's just that the current data are not good enough to detect it. The uncertainties are too large. So definitely something that we will want to look at as data gets better. So now we get to essentially the crux of the question. We wanted to know how many people are likely to die in South Africa from COVID-19. And so we said, well, what is that? We need the average IFR for South Africa, and we need to know how many people will be infected. So in a sense, it comes down to those two questions. We now have a lower bound on the IFR from New York, etc. It's like about 0.2%, at least in overwhelmed healthcare scenarios. And unfortunately, I think our healthcare system will be overwhelmed. So 0.2% is a lower bound I think we can trust. And then the question is how many people will be infected. So let's have a look at those two questions. So the first thing that we have to deal with is the fact that the case fatality rate, so this is not the IFR, this is a CFR. So this is given the people who tested positive, what was the fatality rate as a function of age? And I'm sure you all know that it's a very strong, this is from China, it's a very strong function of age. In China, it was going, it was below 0.2% roughly for anyone under 40, growing to 15% for people over 80. And in fact, it's probably actually even stronger variation with age when you deal with the kind of statistical issues. So that's great news for South Africa, because what I'm plotting here in black is the number of women in South Africa as a function of their age. And you can see that, it's roughly flat until 40, and then it drops very fast. There's only a very few, I think it's maybe 5% of South Africans are over the age of 65. Compare that in orange to Holland, where you see that there's a very significant older population. So when we take that into account, and we can do this for the whole world, so here I plot basically every point as one of the world's countries. Here's the effective case fatality rate versus the number of people in the country. And what you can see up at the top is Japan, which had a case fatality rate on average. So in Japan, for every 1 million people that get infected and get test positive, they would expect 30,000 people to die. Down here at the bottom are the very young countries. So Africa is all down here at around about 0.5%. And so in fact, you can look at that and you find that Italy was about 2.6%, America 1.9%, and UK 2.1%. So Europe as a whole is 2.1%, and Africa as a whole is about 0.5%. So in principle, this is fantastic for the third world. The third world does tend to be very young. And so, in fact, this is the case fatality rate, so tested positive. So for Africa, you know, the IFR might actually be on average like down at 0.1%, essentially because it's so young. That's the good news. The bad news, of course, is that the case fatality rate is very strongly dependent on comorbid diseases. So for people in China, these are the Chinese numbers, people with cardiovascular disease, the case fatality rate is 10%. For diabetes, 7%. For chronic respiratory disease, 6.3%. Hypertension, high blood pressure, which, you know, half of South Africa may have high blood pressure, 6%, higher even than cancer. And for those who have no underlying health condition, irrespective of age, is even under 1%. So the real question, of course, what you don't see there is, what about HIV? What's the case fatality rate for HIV? Well, I think 6 people in China had HIV and got COVID, and 1 of them died. So, I mean, we basically have no data. More data is becoming available from, you know, America and Italy, etc. One curious thing that I noticed, and perhaps other people have noticed as well, is that you would have expected more people with HIV to have got COVID, given the prevalence of HIV in those countries. So fewer people with HIV were getting COVID than expected, or at least were getting tested. So of course that could be that people with HIV are just very clever and realize that it could kill them, and so they're shielding themselves very effectively. Or it could be that somehow something else is going on. So the bottom line is, we have no real idea of how this comorbidity effect will have an impact on South Africa. We have 8 million roughly HIV patients. Many of them are taking antiretrovirals. So will that help? Hopefully it will. We have high hypertension, high TB, lots of malnutrition. But let's just be super optimistic and assume that we have a 0.25% IFR on average. So that would tell us that we would expect at least 15,000 deaths per 10% of the population. Okay. So if you think that 50% of the population of South Africa will end up getting infected with COVID, then you would predict a lower limit of about 75,000 deaths, I think. So that's my kind of, personally, that's my best case scenario. 15,000 deaths per 10%. But the downside is, if these other comorbid conditions turn out to be very bad, the IFR could actually be much higher. Could be significantly higher. It could be 4 times higher, potentially 5 times higher. So, well, you know, we said 15,000 deaths per 10%. Well, so how many are actually going to get infected? So let's have a bash at dealing with that. Any questions? Yeah.
Yeah, can I just quickly ask a couple of questions which people post? I mean, like the first question is from Alan Matthews, and what is the HIV prevalence in China? So how the prevalence in South Africa and in China compared to each other in HIV?
Well, I did look at this. The prevalence in China is quite low. If you just Google it, you'll find it very quickly. It's of course estimated. I can tell you that for 6 people out of 80,000 to be infected, that was low, but not insanely low. So, you know, in South Africa, it's 15% or something about of the population. In China, it's much lower.
Okay, thank you.
Okay, awesome. Any other questions?
No, because there are comments, but not the questions.
Okay. If there are any comments saying I'm completely wrong, then, you know, that could be a good discussion point.
No, there are comments which are saying that the people are very sympathetic to the idea that it's very difficult to make predictions when there is so many variables to take into account.
Absolutely. Well, Koos Becker wrote an article recently in which he said predictions in such times of crisis I can't exactly remember his colorful phrase, but basically only idiots make predictions. So let's be an idiot and make some predictions. So to make time-dependent predictions, we need to know about how the disease spreads. And so let's look at very simple models. And these very simple models typically depend on a quantity known as R0 or RT. So R0 is called the reproductive number. So it's, if I'm infected, on average across the population, and you can already see where the problem's going to come in, how many people do I infect by the time I either die or recover? So that's R0. And for COVID, estimates are somewhere between 2 and 6. RT is the same quantity, but as time progresses. And as we saw, RT can change because we can socially distance, we can wear masks. So it will change with time. RT will also change as you start to head towards herd immunity, the infamous herd immunity. So, you know, once a large fraction of the population gets infected, the number of people you can infect goes down, because basically it's hard to find the people who haven't already been infected. So a bit like a fire will tend to go out without having burnt everything. And so for countries around the world, once they start making interventions, we see that RT is somewhere between 1/2 and 2, roughly. So why is R0 and RT so important? Well, in these simple models, if R0 or RT is bigger than 1, then you're getting exponential growth. And you basically keep that exponential growth until you reach a fraction, roughly 1 minus 1 over R0 or 1 over RT. That doesn't mean that you will stop there. It's just that at that point, it kind of turns over and the growth stops being exponential, becomes kind of polynomial. But the real important thing is that from your value of R0 or RT, you can predict what the final percentage of the population will be infected, or the final fraction. And you can see it here. So the blue dots are actual simulations that we've run on, you know, more sophisticated models. And you can see that it varies. For an R0 or RT of about 1.5, you end up with about half the population being infected. For R0 or RT of 2, you end up at about 80% of the population being infected. And then, of course, if R0. So, you know, we said that R0 is somewhere between 2 and 6. And so you see that you predict somewhere between 77 and 90% of the population need to be infected. So, you know, if we go back to this naive calculation that we did, which is, 15,000 people, as at best, 15,000 people will die per 10%, you need to be multiplying that by 7 or 8, a factor of 7 or 8, if you think that RT or R is somewhere in the range of 1.5 or above. So that tells us the rough kind of order of magnitude. Let's have a look at Italy. The estimates from the Imperial group, or, you know, Ferguson, his group estimated that RT initially in Italy was somewhere between 3 and 4. These are the confidence bounds, 50 and 95%. They then did school closures that reduced RT by about 1. So that's slightly worrying for us in South Africa. We're about to reopen schools. Definitely, if it jumped by 1, we're in trouble. And then they did a whole bunch of other things that progressively led to total lockdown, and then RT ended up below 1, and that's sort of how this game is played. So this is just a model, and it's really important to remember that any forecasts are just based on models, and all models are wrong, but some are useful. And so the question is my model useful or not? And so that's sort of the question I'm asking here, and that I want to kind of put to you. Are any of the models that we're using useful? Are they correct? And if they're not correct, in what ways are they not correct? So what we chose, so I'm sure you will have seen the national predictions came out last week. There's the Actuarial Society of South Africa put out projections. and they put out projections for specific models. And so we decided not to do that. What we did is we simulated many models, tens of thousands now we've simulated, that we believe are consistent with what we know about the disease. And here's an example of 10 RT curves over time. So day zero for us is the 1st of May. And you can see that different models encode very different beliefs about what the future might look like. Once you put 1,000 of them together, you get a wide range of possible scenarios. And so these scenarios are trying to allow for the fact that we still don't understand the disease. What is the IFR? What is the total time of infectiousness? What is the effect of climate? What is the effect of adding masks? Oh, how much will the community comply? If the government in 2 months' time says we're going to level 5, will people comply or not? How efficiently can contact tracing be done in the next 3 months? How well will quarantining work? What will the government policy be as it tries to open up the economy? Is there more than one strain active? So, there's a huge amount of uncertainty. And so we try to allow for that uncertainty by running scenarios, a wide range of scenarios. And you can see some of our scenarios go below 1, an RT below 1, which means the disease starts to be snuffed out. We start to get control of the disease. And I think this is possible if everyone wore masks, if we got really good at quarantine and contact tracing. South Korea, Taiwan, other places have shown it is possible. But will we be able to do it? Maybe, maybe not. And so it's sort of a betting game. It's a bit like the stock market. You have to, you place your bet and you take your consequences. So what happens when we run 1,000 models like that? This is the sort of thing that we get. So top left are 1,000 models for the number of people in ICU as a function of time. So again, day zero is the 1st of May. We see an exponential growth and then turning over. Here's the number of people in hospital. Again, a lot of spread. Here's the cumulative number of total cases. You can see a lot of cases end up in the 20, 30, 40 million regime. There's a few down here in which you have only 5 million people infected. Those are the ones in which quarantining and contact tracing really work beautifully. And let's hope that those are the right ones. Okay, and then finally up here in the top right, you have the number of fatalities over time. And you can see, unfortunately, that they include models getting up towards 500,000-600,000 deaths. And in black here is the progression of the deaths over time since the 1st of May. And for this run, most of those 1,000 are actually below this number, unfortunately. So we can take slices through these through these time plots at different months. Oh, so just to put it in perspective, this roughly is the number of ICU beds in South Africa, around 4,000. So you can see these are log plots. So we hit here. Some of these hit 100,000 people in ICU at some particular date. There's 4,000 ICU beds. So here's the number of deaths over time. So on the 1st of June, here's a slice through those histograms. So the median prediction for 1st of June, in this case, was here's 1,000, 987, 500 people dead on the 1st of June. These two dashed lines are the 95% confidence interval. And then we've got the same for July, September, and the maximum. And so here you can see that 50% prediction is around about, 120,000. But the model goes down to, 8,000, 7,000. So there are some cases where very few people die, but 50% of the cases have more than 100,000. And it goes out to, unfortunately, 2, 3, 4, 500,000 deaths. And just a comment here that the ICU overwhelm is critical. It roughly doubles the average number of deaths. So I'm not sure if the other models that people have produced have modeled this ICU overwhelm, but we found that it was critical. These results are very sensitive still. Even though we're running thousands of models, they're very sensitive to our assumptions about how many asymptomatic people there are. And so, for example, if we say that we think that there's a lot less asymptomatic people, and we think that maybe the testing is actually quite efficient, then that means that the IFR goes up, and then we basically double the number of deaths. So you can see going from 120,000 on median up to 200,000 median, and we end up with more than 1 million dead in the worst case. Just remember, there's only 2% probability that you're to the right of this dashed line. So fortunately, these are not typical, but still, the fact that even a couple of percent of your models end up with 1 million dead is not good. The good news is that there's still some models with very few deaths, but yeah. So in summary, my main point about this is that precise answers about predictions just aren't possible, and anyone who claims that they are, well, is using a model that's essentially a guess, a belief about what the world is, which may or may not turn out to be true, but is not justified by what we currently understand, the uncertainties we have about the world. And when you change those model predictions, your results change exponentially. So, you know, the things that have a big impact are the virus parameters. You know, how long are people infectious for? What's the effect of climate? What's the government going to do? You know, if the government decides to not go below level 3 until this is over, that's a very different world than if the government says, okay, we're going to go to level 1, even though 50,000 people have died. Perhaps someone knows what the government policy will be, but I don't. And nobody knows whether the community will accept it. You know? We don't know what the effectiveness of the interventions are going to be. So, you know, all of these things I think just mean that my point is I certainly don't believe any single models that people put out. And, you know, in the extreme, you'll see people making predictions that are accurate to, you know, 3 or 4 decimal places. Just go back to Sweden and Qatar and ask them to predict how many deaths will come from 40,000 infections. And they will not give you a 200-fold variation from 23 up to 4,000. So that's my main thing is that at this stage, we really can't predict with any accuracy. So to wrap up, I think we are now sure that at least in overwhelmed health systems, COVID-19 is definitely worse than the flu, at least by a factor, at the minimum, a factor of 2, but more likely a factor of 5 to 10 to 20. There's unfortunately no evidence for mitigating effects from BCG. For example, I saw recently that a relatively large group of care workers were given the BCG vaccine, hoping that this would have an effect. Let's hope it does have an effect. Unfortunately, there's no evidence for that at the moment. Something like 50% of our models have more than 100,000 deaths, but there are also models that have only 10,000 deaths. You know, so roughly, I would say at this stage, 5,000 deaths are as equally likely as 300,000 deaths. So there's still a lot of hope, you know, if we can get things right. But the downsides are definitely there potentially. And you know, I'll just end by saying that, you know, doing these interventions can, you know, like going into lockdown, etc., can reduce RT significantly. But if you cannot get RT below 1, you're still growing exponentially. You're just growing very slowly. And eventually, you have to face this curve. So if RT is 2, eventually you will get to 80% of the community having been infected. And the spread of the disease will shut off in that case, as long as new strains haven't evolved for which people don't have immunity. So, you know, for New Zealand and for Australia, they have managed, it appears, and China, it appears that they managed to essentially get the disease under control. But the problem is, as soon as they let go, unless they're incredibly vigilant, the disease will return to an R0, and then you'll get a new explosion. So, the pandemic of 1918, the Spanish flu, showed that, you get it under control the first time, and people, of course, want to go back to living their lives. And then there's a second wave, and third. It could be that there are multiple waves before we get the vaccine. So, my own feeling about low predictions on the low side is that people have not really thought about what's going to happen in 2-3 years. And you can sort of see it if you look at this plot of the cumulative number of cases. There are these models in which by the end of the year, 240 days from the 1st of May, you've only got 5 million people infected. The problem is when you run those forward another 200 days, they all increase to much higher values, 10, 20, 30 million people. So, we have to think about policies that may be in place for the next 18 months. So I think, that's probably a good place to stop. Take any questions if there are.
Yeah, thank you very much.
Thank you.
For the fantastic, honest and very realistic and down-to-earth kind of talk and picture of the situation. Ilya, are there further questions from the participants for Bruce?
Yeah, there are a few more questions. Okay, so there is a question on the, so from the Justin Jonas is, what fractions of symptomatic cases end up in hospital, get by the just oxygen therapy, or need more intensive therapy?
So, hi, Justin. We don't know. So unfortunately, well, in China, the results were that 5% of people needed ICU, 20% of people needed hospital, and 80% were mild. But clearly, that depends on your testing strategy, right? If you only test very sick people, 80% of the people are not going to be mild, right? You're going to have 80% of the people being in hospital. If you only test people in hospital, well, then 100% will be in hospital. So the question, in a sense, is how much are we like China in terms of testing? And I think, unfortunately, we probably aren't as good as China. Qatar is probably in that zone of number of tests. So the best case scenario would be what China had, which is 20% of people in hospital. And in fact, I think that's what we assumed in these simulations. I think we took 20% as our base model and then allowed for a standard deviation of 5% around that. So Italy, I think they were more like, I remember statistics somewhere around 10% of people needed ICU. And that is a combination of two things. One, they were testing much less than China, but also, of course, they have a much older population. So you would anyway expect a higher proportion of the population to end up in more serious kind of endpoints of the disease. So I think everyone tends to take this 80-25 ratio of mild, hospitalized, and ICU. But I think that's optimistic. And in South Africa, we have a younger population, which is great, which the healthy part of our population should have a lower than 20% of people ending up in hospital. But of course, we've got the comorbid counterbalance. And so nobody knows yet how those two things will square up. In terms of oxygen, I can't really comment, of course, because I'm not a medical person. So, yeah.
Okay, so a little bit on the another note, and just kind of like on the what would government need to do, and kind of in this matter, Anand Kumar is interested as far as affecting the economy is concerned and the controlling the spread of the virus. What would be the ideal mix?
Yeah, that's I would love to know the answer to that. Partly that is unanswerable, and partly it's just very difficult. So let me talk about why it's unanswerable. The first thing is, it's the trolley problem, right? You have to decide, is a person who's 80 years old, or someone with HIV, or someone with TB, is their life the same as the life of worth the same as a life of a 20-year-old? Okay, so and if it's not, how much less is it worth? Is it worth less? Is it worth 5 times less or 10 times less? Clearly, everyone will have their own decision about that. So the decision of what to optimize when you're balancing going out of lockdown versus people dying from COVID, that everyone will have their own opinion of what exactly that should be. In a sense, it's a bit like if I ask you, what's the optimal balance between bass and treble? You know, there's no right answer. You do your personal preference, and it's the same with this question. So what you optimize is completely personal. There's no right answer. Once you've decided, let's say the government makes a choice. We think a person who's got 10 years left to live, his life is worth 50% of the person who would have 50 years left to live. Once you make that decision, it's still an extremely difficult problem, because now you have to try to compute what are the consequences of all the different policy decisions you might make. If we went to level 3, how many fewer people would die in the next 5 years than if we stay at level 4? You know, I mean, if there was a lot of uncertainty in these COVID models, there's probably 10 times more uncertainty, because you need to try to predict suicides, murder, malnutrition, starvation. You know, it's just an incredibly difficult problem. But it is the actual question we have to try to estimate if we wanted to do this scientifically from a kind of effective altruism kind of point of view. So, I don't know. My own view is we went to level 5. We didn't get RT below 1. Therefore, there's no point staying at level 5 or level 4, because all we're doing is waiting. So just to go back to this curve, where is it? If you manage to bring RT down to 1.2, 1.3, which is sort of what South Africa did on level 5, great. And if you could keep it like that for 3 years or something, fantastic. You would only end up infecting, you would only need to have 30% of the population infected to shut off the disease and basically eliminate it. But the problem is, it's coming at a huge cost, right? So it's not like New Zealand, where they can actually try to completely eradicate the disease. We're just waiting. And then as soon as we go out of that and we go back to 2 or 2.5, then you'll go back to very rapid spread of the disease, as shown. Well, these models, none of these models have R above about 1.5, but what you would see is a very sudden spike in deaths. So the analogy I have is, you decide you're going to shoot yourself at 8 o'clock tonight, and at 5 to 8 you get a phone call from a friend who chats to you for half an hour, and then you hang up and then you shoot yourself. You know, delayed your death by 25 minutes, but so what? You're still dead. You know, so in essence, my argument is we may need to have the strictest lockdown that we can that is still sustainable for 18 months. So, and at that point, you know, we will flatten the curve as much as we can. We will get an RT that's as low as possible. We want RT to be as low as possible, but, you know, whatever happens, we're going to have to sustain it for a long period of time. Unless we get a vaccine, of course. And that's, of course, the other big unknown that we don't know is how long will a vaccine take, or if we will ever have a vaccine. It's that there's some probability that we will never have a vaccine.
Okay, so there is a comment and a question from the Jules Ramon, and it's, he's just generally fascinated with the kind of the complexity of the model, and he is interested in how the reliability of the test have been taken into account.
Oh, yeah, a great question. No, not at all. We didn't, you know, there's so much variability here that we haven't explicitly modeled that. What you can see is that today is day whatever. So you can see that this is the range of total cases that our models have. So you can see that some of our models are saying that there are actually 200,000 actual cases in South Africa. So that's roughly the 10 to 1, 12 to 1 compared to the actual cases we have here. So testing reliability could be included as an extra factor, but it would be a 20% effect, whereas the other, our general ignorance about the IFR is a 500% effect.
Okay. Mike Murray is curious whether it will be possible to get access to the data used in your model and predictions. Is it published?
Sure.
Is it available somewhere?
We will be publishing it, yes. Absolutely. We will publish also the actual code so that you can run. I mean, what's nice is it takes like a couple of minutes to run 1,000 models. So we will be releasing everything. I think, and in fact, there are now many websites around the world that will allow you just to put in South Africa's parameters, put in an intervention that you think will happen. You might say, oh, no, this is rubbish. I think RT is 1.5, and then it will jump to 3, and then we'll get quarantine. You can put in your interventions, and then it will produce a prediction for you, and then you can see for yourself. So, yeah, so definitely look for COVID simulator. There's a few good ones which include South Africa in it, but we will also be releasing our code.
Okay, thank you. And there is a comment from the Rob Adam on the kind of your trolley question is, or kind of trolley problem, is that maximizing the estimated cumulative number of the years to live is the way to answer this question in a rather Machiavellian fashion.
So Rob, I disagree completely with you because so it's a reasonable thing, but it's not unique. Because what about, you might say, it's not the total number of years to live, because that includes people who maybe don't contribute to the economy equally. So maybe you want to weight the years to live, years left to contribute to the economy. And some people, the really Machiavellian people, would say that's the thing you want to maximize. Other people would say, well, for example, it's now becoming clear that COVID, even for those so-called mild cases, it's actually pretty unpleasant, and I'm experiencing this now. I think I have COVID, and it's extremely unpleasant. The amount of fatigue is extraordinary. So I'm not dead, but maybe my effectiveness in my work has dropped to 20%. So should you include that in your estimates? So there'll be a number of what about anguish and pain? Do you include that? Do you, so there are a number of kind of buttons and knobs that you can twist that will change the function that you're trying to optimize. Number of years left to live is good, but what if it leads to a 20% reduction in GDP? Is that the right quantity? If you suddenly, if the number of people living in poverty doubles, but you manage to save a lot of lives, is that the right trade-off? Or should you be including the number of people who go into poverty as a result? So, yeah, I think you can do sensible things, but there is no unique answer. Sorry. It's really hard because I don't see anybody, so it's really hard to stop rambling.
Okay, that's it, and just kind of compliments from the Andrew Forbes and Anna Bastian on the very nice talk.
Fantastic, thank you.
Yeah, Bruce, then this is probably the moment to thank you and to thank the participants, but I really would like to thank you for showing us how the most objective use of the best analytical tools that we have at the moment clearly shows on the one side the power and at the same time the limits of what we can say about a very complex situation. But also I was very, very grateful to hear that all you do is open, so that you're also in the spirit of open science and happy to share your data and your codes. That's also very, very, very good news and very interesting, so that everybody can look into the modeling and try the best at coming up with a solution to this very complex and multifaceted problem that we are all facing together at the moment. So every talk needs to come to an end, in particular if it lasts more than 1 hour. So Bruce, thank you very much again for the very nice and interesting talk. Thank you very much, Ilya, for moderating the questions and the answers. A big thank you to all the participants. And soon we will announce the next NITheP colloquium, probably already next week. And maybe some of you have noticed that since last week, NITheP has a new website, so please go and visit it. And so I wish you then a good evening, and please stay safe. And Bruce, take care of yourself and get strong again quickly. Yeah. Thank you very much.
Thanks so much, Francesco. Thanks a lot.
Thank you.
Bye-bye. Bye-bye.